The information provided on this podcast is for educational purposes only and isn't intended as medical advice. Always consult with your doctor before making any changes to your diet, exercise, or health regimen. Let's go to the show. Welcome back to another episode of Soma Says. Today I'll be talking with Dr. Asma Khapra, who is a gastroenterologist with specialty in women's digestive health and inflammatory bowel disease, with an MD from the Johns Hopkins School of Medicine and training at both Weill Cornell Medical Center for residency and fellowship training at Mount Sinai in New York. Dr. Khapra is a gastroenterologist at Gastro Health in Northern Virginia, and she is also the co-founder of Olvi Health. Welcome to Soma Says, Dr. Khapra.
Thank you so much. I'm excited to be here and talking about something I love dearly. So I became a gastroenterologist really because, first of all, I loved the field of GI. I loved the pathophysiology. I loved taking care of GI patients, and I loved the people who went into GI. So it was a great fit for me. But when I became a gastroenterologist, what I really loved most was taking care of women and really being able to care for women in a way that's unique to women. And when I say that, I mean that I think in medical care, a lot of times the focus is just on the general patient and what the guidelines say and what the general, basically, principles are. But when you talk about women, I think women have very specific needs. They have very specific changes in their life. And I think that taking care of women is a very special thing. And when you talk about digestive health, so many different things that change with women over time. So in my practice over the last 17 years, and I've been in clinical practice that long in the Washington, D.C. area, I've developed a very special interest in taking care of women, both digestive and their pelvic health. And I see women from all kind of ages, from their 20s all the way to menopausal age. And we deal with a lot of different conditions that occur during that period of time. And I really think that the care of women should really be tailored specifically to each woman based on where they are in their life, where they are in terms of their hormonal cycles.
You were saying that your practice is about 95% women, which is a lot. I also specialize in women's health, and even then my practice is about 50-50. So what made you so interested in the GI aspects of women's health? Did you find that there were things that were missing in our current state of medicine?
I think it evolved over time. One of the things in GI is that there's not a lot of female gastroenterologists. In the era of screening colonoscopies, women tend to seek out female physicians. There's slightly higher female population because of that. But I would also say that I think women, physicians in general, tend to listen and communicate a little bit better with women patients because they tend to have a little bit of a different style and sometimes a little bit more patience and a little bit of a different feel than it is with a male gastroenterologist. And I think that because of that, I developed really tight relationships with my patients. And over time, I've realized that what people have gone through really requires an in-depth discussion with your patients. A lot of it involves asking questions that are not the normal questions. For instance, like how many pregnancies have you had? Were they traumatic deliveries? These are all questions that require a little bit more time, effort, and knowledge. And I think as a woman, you're aware of that and you're a little bit more open to that. And I think female patients are also more open to discussing it with you as well.
We have a different appreciation for these kind of things with our own bodies, right? We go through this stuff and sometimes I even get confused and I have to figure out what's going on with my body. As we go through the different stages of being a woman, can you explain how hormonal fluctuations during the menstrual cycle can affect gastrointestinal symptoms in women?
Unfortunately, the research is really lacking in this area, but I will tell you things that we do know. So that'll make it at least a baseline of what we can go off of. We know that there are estrogen, progesterone receptors in GI tissue from early fetal stages. So we've seen that in animal studies. And we know studies have shown that there's sex hormone changes can change gut motility, intestinal permeability, even barrier function like immunity of the gut. And so studies have shown all of this kind of on an animal level. Now, small clinical studies, and these are very small studies, have reported that during menstrual cycles, right before menstrual cycles and during menstrual cycles, you will see that women have flares of certain conditions, for instance, IBS. And we know that's definitely been seen in clinical studies. And you also see it actually in inflammatory bowel disease as well. So clinical studies have shown that at the time when there are these sort of hormonal surges, there are clear flares of certain disease states. Now, the exact link from one condition or in terms of one hormonal change to the other is not that clear. The only thing that pretty much is generally understood or generally accepted is that progesterone can slow down GI motility. And when it does that, it can cause, some constipation. It can reduce the lower esophageal sphincter pressure and cause some reflux. But beyond that, there's not a clear link to say X change causes X symptoms. It's more of things that are seen during small clinical studies.
Patients who may have a flare with their IBS when they have their menstrual cycles, what do you recommend for these types of patients?
So it's interesting. So the one nice thing about it is that it's predictable, right? Or for a lot of people, the menstrual cycles are predictable. So if they are having IBS symptoms during their cycles and they know what's going to happen if they're on certain medicines that they use as needed for IBS, I recommend that they start taking them as soon as they the minute they start feeling symptoms so that they can be proactive about their symptoms. So that's definitely one way to do it. The other way to do it is also to change your diet a little bit. If you feel like there are definitely things that trigger you, then around this time your gut is extra sensitive. So you need to be a little bit more cautious with your diet. So a lot of it is just really being in tune with your body and making those adjustments because IBS is like a chronic condition like any other chronic condition. It'll have ebbs and flows. And so a lot of people who deal with it chronically have a little armamentarium of what they do. And because menstrual cycles can be predictable, I tell them to be aware of that. And part of it is just making patients aware of the association.
When you see patients that have hemorrhoids or even incontinence, I know you're a gastroenterologist and you don't deal with urinary incontinence or anything in that area. How do you teach your patients about pelvic floor issues related to pregnancy or even after when they're perimenopausal and menopausal?
I think pelvic floor is a underemphasized area generally in female women's health, especially in GI. So I think that as soon as women become pregnant, or I guess as soon as they have pregnancies, there is a risk that the pelvic floor will become a little bit more lax and you will over time even develop pelvic floor problems. So I always tell people who have GI issues, like never to strain because that will make the pelvic floor worse. I give them really techniques on how to go to the bathroom and what I call bowel hygiene in terms of making your regular movements comfortable. And so you don't exacerbate maybe potentially pelvic floor problems that could happen over time. And then it's interesting, actually, one of my friends who's German had said that after pregnancy in Europe, everybody does pelvic floor physical therapy as a routine. It's part of what happens after pregnancy. And so it was an eye-opening phenomenon because I think we don't talk about it as much. We certainly don't send everyone to pelvic floor physical therapy, but I am very in tune to if any woman has a GI issue that I at least ask about, pregnancies, because that will impact your bowel movements. And I'll give them certain techniques, things that they can do to make sure that doesn't get worse over time. Because we do know that people, for instance, who have multiple pregnancies that have fourth-degree tears, they are at higher risk for fecal incontinence. And that starts in their 60s. It won't happen immediately, but it'll happen over time. And so just aware about these things and making changes in the way you manage your bowels on a daily basis impact you further. And I am very open and very proactive about sending anybody I think might need pelvic floor physical therapy to a pelvic floor physical therapist. And for GI, it's very specific. There's a whole world of biofeedback, for instance, for people who have constipation. And so it's a different type of physical therapy that
there's this whole movement, which is great, about knowledge and empowerment about women and menopause. There's so much out there now, and hopefully there will be more. It's a very common thing that I approach with my patients, but a lot of women are just focused on the hormonal issues. Can you talk about some of the GI changes, the gastrointestinal changes that women might experience going through perimenopause and menopause?
Sure. So the biggest ones that we've seen, at least in the studies, are perimenopause and then menopause, are reflux and constipation and bloating. And those are probably the biggest things that we see. And then, as I mentioned before, later on, people can get pelvic floor related issues that progressively can get worse. But from a symptom standpoint, those are the big three. And everybody's different. So people are not all the same. It depends on what generally your background is in terms of other medical issues, et cetera.
How do women address these changes in their bowel habits? Do you focus obviously on colonoscopies and making sure that they're up to date with their colon cancer screenings? And do you help to educate them about how they can regulate their bowel movements?
So you always want to make sure, obviously, that you address any basic screening. And I think that's important because these are the ages when you start doing a lot of the screening. So colon cancer screening starts at age 45 if you're average risk, but earlier if you have a family history. So that is always the one thing you want to check off on the box. Once you've done that and you don't see any other alarm signs, and a general small workup has been done to make sure you're not missing something else, I always make sure I get a good history because I think often, particularly during perimenopause, women have a lot of other changes. And what you may realize is, for instance, if someone comes in with reflux and they have no idea why, but then you ask about all these other changes in their body, and then they start mentioning, oh, I've been having joint pains and I have been trouble sleeping and some hot flashes and, oh, my periods are off. Then it puts the picture together a little bit. And then it makes it like a little bit more comfortable for you to say, hey, maybe this could be related to these hormonal changes. And once you feel, okay, this is what we're dealing with, then we talk about everything from lifestyle to diet, and then to supplements, and then to medications, kind of as last resort, but depending on how bad their symptoms are. So it ranges the gamut. And I think that most people are open to really doing this sort of holistic approach to treatment when it comes to that. And a lot of it is reassurance, honestly. When people come in, they're really worried, like why they're getting these symptoms all of a sudden.
In your experience, from the more conservative things like lifestyle modifications or possibly supplements to hormone replacement, what do you find the most useful in terms of treating the GI issues that arise during this stage?
One of the things that I think is everybody is just so different, but I will think that one thing that I will tell you is that I think making really clean diet choices are helpful and avoiding things that really make symptoms worse. So if it's reflux, taking out a lot of caffeine or a lot of the specific triggers are really important. But if it's the constipation end, it's like really adding a lot more fiber to your diet and making sure that you are hitting a goal of 25 to 35 grams a day, because it's hard to do for the average American typically gets 10 grams. And then the other big thing I think is exercise. I'm like a huge proponent of your gut is a muscle and you need to exercise it like you would do anything else. And you would be so surprised how much constipation will improve with exercise. So I'm a big component of not just, but also like physical exercise, cardiovascular exercise.
I think these are very important things because no one medication can obviously work and solve the whole thing. I think in terms of our listeners, a lot of women want to understand what's happening to their body because it's such a different situation for them. So what happens to the gut when these hormonal imbalances happen? Would you be able to illustrate on that?
I'll give you a couple examples, I guess I should say, just to make it a little bit more what's going on at a microbiome level. So it's interesting because estrogens has been shown to increase the diversity of the microbiome. But we know in menopause, there's a lower estrogen state. And when you look at the microbiome of women who are in menopause, it actually looks similar to men because they have this different kind of microbiome. So we know things are happening on a microbiome level. There's actually like a whole area study called the microgenderome, which talks about microbiome changes in different genders. But I also mentioned motility is a big issue as you get older. And because of the hormonal changes, like you will see that gut motility really does slow down. And that I think really contributes to constipation, for instance, and which also reverberates to bloating. But that also has other pathophysiology. I think the motility issue is also another big issue because it is really impacted by hormones. And so I don't think it's one big thing. It's really a combination. If you put the motility on top of what's happened to the pelvic floor already, then you really are just stacking up the odds of having these kinds of symptoms.
I asked that question just because patients ask all the time. And of course, I go into the imbalances that happen and how it impacts the gut. Sometimes they have a hard time understanding how things change to their bodies that was like working perfectly well before. In your practice as a gastroenterologist, in the research that you do, are you seeing any emerging treatments or research findings that we may not know about in the field of GI that you're excited about? Anything coming down the pipeline or that's already here that you're excited about?
I wish I could be more excited because I wish there were more research in women in particular. I think that's really been lacking specifically, but I do think there is a bigger general push in the functional bowel world. And I think part of that will impact women because you see 60% of functional bowel disease are proportionally women. So it disproportionately affects women anyways. And so a lot of these types of conditions that we're talking about are really under the world of functional bowel disorders. And there's a couple things that I think are really interesting. And it may not be, it's come down the pipeline, but it's becoming more and more used. But one of the nice therapies that we are finding, for instance, for IBS and functional bowel disorders is things like gut-directed hypnosis and cognitive behavioral therapy for the gut. And these are now become part of the algorithm for GI care for functional bowel disorders. And because there is higher rate of these problems in women, I think this allows you to have so many more options to treat women because that are not medications, that don't have side effects, and that can be really beneficial on a long-term basis. I have a woman here who is doing some really interesting work in gut-directed yoga. And so I send her a lot of my patients to do really deep breathing and yoga exercises in order to relax their diaphragm and improve some of their GI symptoms. So I think this is a very interesting area, which will have a lot of implications down the line for treatment. And in the same token, which it's happening, but it hasn't moved as fast as I would like, the world of microbiome. So there's so much going on in the microbiome world, but I think that the microbiome is extensive and it's so much research that needs to be done. And I do think over time, there will be more and more that we learn that hopefully will give us other tools to treat women on.
I'm curious, with
over
the
these.
GLP-1 receptor agonist, every other day you turn around and there's a benefit, cardiac benefit, kidney benefit. Have you seen any benefits for the GI system with these medications?
The biggest issue is these drugs basically functionally slow down the gut. They basically cause what's physically cause gastroparesis, or slowing of the gut stomach motility. And what that does is it creates nausea, vomiting, and constipation. And so in our world, we see a lot of people coming in complaining of side effects. Now, it's interesting because I do think that when people who are very overweight or obese, they will have a lot of benefits to losing weight. Their reflux gets better, their IBS will improve, but it is sometimes difficult to get them to tolerate these medications. We have actually seen a lot of side effects for it. I am not someone who tells patients not to take them, but I give them very specific instructions that when you start these medicines, you should start at a low dose and you should literally eat half of the portion that you're going to eat. And you should manage constipation immediately so that you can tolerate these medicines over time. I'm not sure what's the world of these GLP-1s is still evolving, and we'll see what happens next.
You are great with patient education and advocacy, and you obviously help women to understand and manage their digestive health. As an advocate for women, what advice do you have for women who may feel embarrassed or reluctant to discuss their symptoms with their doctor?
It's interesting. I had a woman who came to me who had seen a male doctor, but he had retired, and her issue was fecal incontinence. And I started probing and asking questions, and she spilled everything. And then she started crying, and she said, "This is the first time in 30 years I've been able to discuss this with anyone." So I really do feel for patients, because I think it's really hard to discuss it with your GI doctor or with any doctor. I think it's an embarrassing condition if you feel like it's been something that you're not comfortable talking about. That being said, I think you should be comfortable with your physician. I think developing rapport with somebody is very important because it'll allow you to open up a little bit. I think it's important to maybe find recommendations from your female friends that might have seen doctors who are open to discussing these things. It's not an easy thing, but I feel like if you have a good relationship with your doctor, it's easier to have that discussion.
A lot of women patients have a lot of issues, and they don't necessarily feel comfortable sharing everything. So it's important for us as women doctors, especially, to be able to ask about certain things that patients may not readily open up about. So circling back, some question popped into my head about some of the issues that we were talking about. What do you think about probiotics and some of these things that we talked about, like the changes that happen to the gut and the microbiome? A lot of my patients take probiotic. A lot of them have side effects from it. And I have my own take on it, but I just wanted to hear from you what your opinion is about probiotics in general.
That's an interesting question. I think the world of probiotics is so complex. I will tell you my technical answer and then my other answers. By the book, if you look at the AGA, which is our National GI Society guidelines, probiotics are useful in C. diff-associated diarrhea, as well as post-antibiotic-associated diarrhea, and very specific small subsets of other types of diarrhea. It has not been shown that a clinical trial, or the range of evidence is not strong enough to get probiotics and IBS and just general symptoms for GI condition. That being said, I don't think we know everything in medicine, and I think there's a lot to be learned. So anecdotally, I do find that probiotic can help IBS symptoms, and certain probiotics may be helpful in various types of symptomatology from a GI standpoint. I don't recommend that people take them indefinitely without noticing a difference or having a time period where they reassess whether these are making a difference for them. So I usually say, take it for a month. If it doesn't help you, then I would change it or stop it, because then it's not really adding much benefit. At this time point, we don't know that adding a probiotic to at least add a specific species because their microbiome is lacking is really going to be doing anything in the long term.
These things are not regulated by the FDA as a lot of other supplements are not. Not to say that there aren't good probiotics out there, but sometimes it has to be the right match for the patient. Even a good probiotic may not be a match for them. That's been my experience. Would you agree?
I totally agree. And I actually tell them, usually people come in and say, oh, I found the best probiotic. And I said, you couldn't find the best probiotic because there's no best probiotic. Everybody's different and everybody reacts differently to them. So what I do tell them is when you're looking for probiotics, get it from a reputable company. And then also if you're trying a probiotic and it's, for instance, a specific bacterial strain and it's not working for you and you want to try something else, try something of a different strain, like maybe try a yeast species. So you're doing something a little bit different that might potentially help you.
There are companies who test your microbiome and help you understand what's deficient. Patients come in with these reports, right? And I often don't know how to guide them in that way. What is your take on that? Do you find that useful, or do you think it's just emerging research or data that people or companies are trying to put together?
I think it's confusing because I think the data is so sparse and the companies are still evolving. And so they're at early stages where they haven't even gathered enough data of their own to know what this means. So I really do agree with you that it's not clear what this information means. We were just at a GI meeting where they reviewed all of the microbiome companies and what their studies each showed. And basically the takeaway was that the studies are still small. They're a little biased because each individual companies are doing these small studies and we just don't have enough information. So I would tell you that this is the way I tell people. I say, look at the microbiome. They'll tell you whatever information you get from it, but you have to take that with a grain of salt.
So how can a healthcare professional like myself, how can we better support women in understanding and managing their overall digestive health? How would you tell me to approach patients so that we can have a better understanding and help more people?
I think, first of all, I think if female internists or even GYN doctors, if they have a gastroenterologist that they are comfortable with, that they share, that they like their style of the way they take care of patients, they have an interest in taking care of their female patients, that's really important. Having someone as a referral that you feel comfortable sending your patients to. But in general, I think we think of the GI system more and more deeply. So I think one of the things that we can do as physicians in general as a starting place, just give people the tools of eating well, trying to identify basic triggers, taking out the big problematic things that we know are generally fatty food, a lot of preservatives, caffeine, things that we know can trigger GI symptoms, making sure they exercise, like I mentioned, making sure they're getting good sleep. We see how sleep really does impact the GI system. And then trying to reduce stress, because a lot of these functional bowel disorders really do have a huge impact from stress. And so I think all of those things in combination can make a big difference. So I think supporting people as a whole will really impact their digestive system.
I'm so glad that there's been more research, not just with GI stuff, but with dementia and stuff that shows that lifestyle measures really do make a huge difference when it comes to our overall health. What resources or networks would you recommend for women patients who are dealing with chronic GI issues?
So I tell you that, great question, because I think we don't have a lot, but we are starting to get there. So for instance, me and two of my colleagues started a digital health company called Olvi Health, in order to provide more education and resources for women's digestive health. And hopefully that'll be up and coming over the next few months. But in general, from a digestive health resource standpoint, there are big foundations, for instance, like the Rome Foundation, which is the overarching foundation for IBS and functional bowel disorders. They have a lot of great patient literature on them. So it's a great opportunity to learn a little bit more about general functional bowel disorders. I think there's the normal channels that physicians look at. For instance, we look at things like the AGA, which is the American Gastroenterology Association, and the ACG, which is the American College of Gastroenterology. And they have a lot of resources. And one of the resources I will plug in for is something called GI On Demand. And it's founded by the American College of Gastroenterology. And it's actually meant as a patient resource tool for people to learn about various disorders, to be connected to providers. For instance, like they have GI psychologists that you can get connected to, dietitians and things like that. And so GI On Demand is a really great resource for patients because it's all very well validated and it can provide networks of providers.
It was a real pleasure having you on my show, Dr. Khapra. Dr. Khapra can be found at the website gastrohealth.com.
Thank you so much for having me.